First and foremost, thank you all for taking time to join us this afternoon to talk about our NHSN AU option reports. We are so excited to be able to get those out to you all and hope that you find them very helpful. And so, as we kind of talked about in the email, today's office hours session is really for your benefit, but we have a couple presentations prepared. But with no further ado, I will hand things over to Swathi.
Hi, thanks, Kelly. Hi everyone, good afternoon. And many of you may already know me from previous presentation, but for those who doesn't, my name is Swati Vajrala. I'm antimicrobial resistant stewardship epidemiologist with the Arizona Department of Health Services. And I would like to welcome you all for this webinar with the presentation titled A Brief Introduction to the ADHS NHSN AU Option Feedback Report. And many of you received the Q2 2025 reports by this time now. So I would like to go with you what this report actually explaining, like background, introduction, and how we calculated all the tables and everything. So I would like to go with the background. Antimicrobial resistance continued to rise in hospitals across the United States, making infections harder to treat and increasing the risk of poor patients' outcome. Because of this growing threat, the CDC has defined improving the use of antimicrobials as one of the 5 core actions to combat the antimicrobial resistance. So one of the main important tools that support this effort is the AU option within CDC NHSN, which is a National Healthcare Safety Network. The AU option allows hospitals to track and monitor antibiotic use in the standardized way, and also providing the antimicrobial stewardship program can use to evaluate the prescribing patterns. And also some of the studies has shown that when clinician receives timely and reliably feedback about their antibiotic prescribing, such as through antimicrobial use reports, they are more likely to prescribe antibiotics appropriately. In other words, access to the accurate antimicrobial use data will help us facilities to make informed decisions and support the better stewardship practices. Coming to the introduction, hospitals have been utilizing CDC's NHSN, which is the most widely used antimicrobial tracking system, to report AU data for surveillance and the action. So by leveraging this data, healthcare facilities are tracking their data and also identifying the areas for improving the antimicrobial use. And state health departments supported by the CDC have been working collaboratively with hospitals to enhance the antibiotic stewardship activities. A key component of this initiative is a standardized antimicrobial administration ratio. In the short term, we will call it as a SAR, which is a framework that helps facility to evaluate and optimize their antimicrobial use, ensuring better patient outcomes while combating the antimicrobial resistance. And also the data tables and the figures, we summarize the hospital's AU and the provide relevant comparison to the AU of other reporting Arizona hospitals, and also will provide better to understand the antibiotic use and prioritize the antibiotic stewardship activities. And what is the purpose of this report? So the quarterly NHSN AU option feedback, which is created by the Arizona Department of Health Services, which focuses on providing antimicrobial use data to the facilities based on the available SAR categories and also the locations. So these reports will be available to the Arizona acute care and the critical access hospitals that are reporting to the NHSN AU options. And also the main aim behind these reports is to identify the facilities with potentially inappropriate antimicrobial use within each SAR category, and also there is a eligible patient care locations by comparing their performance against the benchmarks and with the similar hospital groupings and the statewide averages. And I will give you the little background behind what is SAR and how we will calculate and everything. So the SAR is a standardized metric of antimicrobial use, which is a ratio of comparing observed antimicrobial use to the antimicrobial use predicted by the referent or the baseline population. The observed antimicrobial is like number of days of therapy or the number of antimicrobial days that reported by the facility for a specific category of the antimicrobial agents in a specific group of patient care locations. And the predicted antimicrobial use is calculated using the predictive models developed by the CDC and applied to the nationally aggregated 2017 baseline predictive model. And also recently CDC updated that in early 2026 there will be a 2023 baseline SARS available with more eligible adult locations, which including mixed equity and the special ICUs and the wards with the 26 adult locations and the 9 pediatric and 4 neonatal. Might be in the future we can see the all reports with the 2023 baseline. And let's see how can we interpret this SAR. So the SAR is always with like either below G1 or the above 1 or equal to 1. So what it means, if you see the SAR value is 1 less than 1, that means antimicrobial use was less than the predicted use. And if it is equal to 1, that indicates antimicrobial use was equivalent to the predicted use. And if it is greater than 1, that indicates antimicrobial use was greater than the predicted use. And also the SAR p-value, which is like 95% confidence intervals, and the percentiles are not a definitive measure of the appropriateness or the judiciousness of the antimicrobial use. Always take clinical judgment into the account when we are interpreting the SAR values. And also we can only calculate SAR when the number of predicted antimicrobial days are greater than 1 and the antimicrobial days do not exceed the days present. And now we're going to discuss about the 2017 rebaseline from the CDC. So this report includes the all adult patient care locations, and for the pediatric and neonatal care locations, those locations and the SAR types will be present soon, depending on the data availability. Now for the oncology and other pediatric locations, we do not have the sufficient data available to include in the report. So now in this report only we have the adult patient care locations. So the eligible patient care locations are the ICU, ward, and the step down. And also we have the list of SAR categories that they are all antibacterial agents, broad spectrum agents used primarily for the hospital onset infections, and also broad spectrum anti-agents used for primarily for the community acquired infection, adult antibacterial agents predominantly used for the resistant gram-positive infection, and antibacterial agents posing for the high risk for the CDI, antifungal agents predominantly used for the invasive candidiasis, and the narrow spectrum beta language. These all are the available SAR categories that we can look into the each how facility is doing and what will be the trends all among the all origin of hospitals. And we did hospital size groupings as well. So to compare the SAR values among the similar hospitals, the following groupings are used for the purpose of this report. So if the number of beds are 1 to 100, then we are categorized them into the small hospital group. And if 150 to 101 to 250 number of beds, then it will be under the medium hospital group. And if it is greater than 250, then it is the large hospital groups. And also in the right last column, you can see the number of hospitals that are falls under each category. Now I would like to walk through some of the tables that included in the report. So I think as many of you have already handed reports. So on the page 5, you will find the adult AU summary section, which consists of several tables comparing antimicrobial use across hospital size, statewide benchmarks, and as well as performance state ranks. I will briefly outline each of this table and how we calculated them. So now look into the adult AU data summary. So this is the first table you might look into, you might look in this page. So first one is observed antimicrobial days and predicted antimicrobial days with the facilities SAR. So the pooled AU rates are calculated to provide the standardized view of antimicrobial use across the facilities, which helps to compare the utilization across the different SAR categories. So these all are the SAR categories that are available. So if we look into one example, let's take a look into the antifungal. So the observed antimicrobial days for the facility X is 923, and with the predicted antimicrobial days, which is 764. So if we do this, if we want to see what is the SAR value for the antifungals, then it will be like 923 divides over the 764, which will makes like 1.21. So that means 1.21 is the facility SAR for the antifungal agent categories. Similarly, if we want to look into the what will be the pooled all antibacterial SAR value, so the facility SAR will be 1.19 if we do the observed antimicrobial use divides predicted antimicrobial use. And also we have like some of the facilities are, and we compared the average facility to for the all AG hospitals. And so in this table, you facilities can compare SAR rate with the statewide averages, and the SAR rankings are based on data from the Arizona hospitals reporting to the NHN for the most recent quarter. So facilities with the low SAR values. So if we look into this table, if for suppose if the BSHO is like facilities SAR 1.1, and if the average SAR for the all AG hospitals is 1.18, that means we like where the facilities value is 1.10 compared to the statewide average of 1.18. And the below table is the example of how statewide BSHO SAR is calculated. So observed days of therapy across all relevant locations, including ICU, step, ward, are summed and divided by the summed predicted days of the therapy for those same locations. In this example, the observed days of therapy of total is 118. The predicted DOT is like 100, which results will give you the pooled statewide BSHO SAR of 1.18. And this table will help facilities to understand what is the comparison of all AG hospitals, and also they rank among the all hospitals. And this table provides comparison to AU of reporting Arizona hospitals based on hospital group. Facilities ranks based upon the number of hospitals in the similar hospital size categories. So in the heading column, you can see comparison to the small hospital groups. If your facility is falls under the small hospital group, then you can compare how your facility is doing among the all other small hospital groups. So if you see similar hospital size SAR, so among the all antibacterial agents, and also the facility ranks when you compare with the hospital size, and where your facility is located when you compare your SAR among the all similar sized hospital groups. And also percentile ranks also calculated based upon the facilities SAR for the most recent quarter year. And I will just go with like what is top quarter. So the top quarter is 76th to 99th percentile, and the second top quartile is 51st to 75th percentile quartile, and the second to bottom quartile is 26th to 50th percentile, which is like among median, and also bottom quarter is 1st to 25th. Based upon the percentile rankings, we assign the performance star, either how your facility is doing, like you're getting 4 stars or the 3 stars or the 2 stars. So these all are performance stars based upon the facilities percentile rankings. And also in this report, we provided for each SAR category and its location to look into the trends over the 8 quarters, which is like 2 years back. And also you can compare your facility exact SAR in that particular SAR category to all the hospital groupings. This is the statewide SAR distribution. So we have here the picture of adult SAR available for both adult and the pediatric for SAR categories. We included the statewide SAR distribution for the pediatrics as well, but might be in the future if we have the enough data for the pediatrics, we will include the all pediatric locations across all different SAR categories. But as of now, we are going to mainly concentrate on the adults. So and if you see the red dotted line, these all are the comparison to the benchmark of SAR. So this is like a statewide SAR distribution. So if we see all antibacterials, which is 1.07, which is above the benchmark, means the all antibacterial SAR over Arizona is like a high. And also if we see the BSCA, it's like a below the benchmark, which is 0.97, means we have to predict that adult all statewide SAR distribution for the BSA is lower than the benchmark, which means like lower use. And also, hospitals can compare 2 year SAR values to track their progress towards meeting specific stewardship targets, or compare a SAR to benchmark value. For example, a hospital that worked to decrease the antifungal agent use for invasive candidiasis in their adult wards and wants to assess the impact for their efforts. This graph will help to understand how you did past and how you are doing in the present, which will help facilities can visualize the comparison to the statewide and the similar sized hospital group as well. And also, this is the second graph that you will see in each SAR category. So this is for facility to compare to the other hospital groupings in the most recent quarter, and the facilities can look into their facilities in the highlighted box. If your facility's SAR is above than expected range, this could be indicate an opportunity for the antimicrobial stewardship interventions to optimize the use. And this highlighted box is your facility, and the remaining hospitals that are most recent year that submitted NHSN AU option data with the similar hospital groups you can find here. And also, you may see some of the graphs without your facility data. You may see only either statewide graph or the small hospital group. You may wonder why my facility does not have the line. That means either your facility does not submitting the eligible patient care location to the AU data, or also you can see there only be calculated. This might be the when number of predicted antimicrobial days is greater than 1, and also antimicrobial days do not exceed the present. Only and also only specific adult care locations are eligible for SAR generation. If we do not have any data related to the eligible patient care locations or the antimicrobial days less than the predicted use, then it will be not generate the any SAR graph. And also, if a facility has submitted AU data in the past and received the reports, but it's not receiving the reports this year, so there may be several reasons. First, it's possible that facility previously submitted AU data for the SAR eligible patient care locations that include ward, ICU, step down, but in the current year, those locations no longer have data submitted. Without current year data for the SAR eligible location, NHSN will not generate the AU or the SAR report. And also, another common reason is that facility may not submitting any AU data at all for that specific quarter. And also, if the antimicrobial use data are not submitted to the NHSN, reports cannot be generated. So, as summary, if for receiving the SAR reports, you should have to eligible patient care location to generate the SAR reports, and also AU always should be greater than 1. So you saw your report, and what will be the next step? So these reports will highlight the different SAR categories and corresponding to their SAR values, and also comparison between your facility and similar hospital groups. So what action will you need to take next? Please note that there is a resources page that being provided with the report to assist further, and you can find related resources under each step in the resources pages. First step is identify the problem by setting SAR target. So unlike the HI target TAP report strategy and SIR, there are no national SAR goals. The SAR target values may differ by the facility based upon the factors such as original SAR values, stewardship priorities, and clinical relevance, such as findings from MUE, which is considered the gold standard of assessing appropriation of the antibiotic use. And also, you can assess the refers to utilize the assessment tools to identify the gap and opportunities to improve the antimicrobial use, and should select the assessment approach for the best aligns with the facility's priorities, resources, and the stewardship activities. And below, you can evaluate the comprehensiveness of the antibiotic stewardship program, such as core element implementation, document entitled Antibiotic Stewardship Program Assessment Tool, while other assessments focus on identifying the opportunities where antibiotic use may be improved more detailed. And the step 3 3 is stewardship implementation. Implement antimicrobial stewardship activities to address the gaps and opportunities to improve the antibiotic use. Facilities, click on all the links that are listed below on each resources to know more information regarding the tasks. And also we have included the FAQ space in the list to answer the common questions about the SAR and the available resources. So we also provided the contact information. If you have any questions related to the SAR report or any data you might have, you can reach out to us for further inquiries. And in summary, the SAR values are like a metric for a variety of purpose. SAR can be used for organizing quality improvement efforts and for benching against external organizations to aid quality improvements and identify which locations may require additional resources or supporting, as well as to measure the progress of targeted interventions. We already sent some of the NHSN AU option feedback reports to the all facilities that are eligible and that have the data for 2025 quarter two. And we have a confidentiality statement that these reports are intended for the internal antimicrobial stewardship efforts only. And ADHS, us, we do not share this information or any hospital level information with any partnering organization, and also planning to send this every quarter. And we are planning to distribute this quarterly shortly after each CMS reporting deadline. Yeah, and I would really appreciate for all your time. And if you have any questions or the concerns, please contact us with the HAI program at agdhs.gov.
Thank you, Swati, for that wonderful and comprehensive presentation. So, my name is Kelly Kronsberg. I'm an infectious diseases trained pharmacist, currently serving as an antimicrobial stewardship and resistance expert within the Office of HAI here at ADHS. So I'm going to be talking about next steps and some of my experiences working with SAR data in the inpatient setting. So, as Swati mentioned, what's our next step? So the CDC recommends a target, assess, steward approach. So we're going to be going through each of those components with some additional context and perspective. So the first one, of course, is going to be target. Now, we do have the comparison as well, so that's going to kind of be our starting point as we're looking at these reports. And as Swati mentioned, we're going to have the different hospital group sizes as well as your hospital highlighted. So in this example, this is a medium-sized hospital, so 100 to 250 beds, that for all their antibacterial agents has a SAR of 0.8, which would be 80% of the predicted use that was actually used. Whereas you might be able to look at some of the small hospital groups that are more outliers, and that's SAR above 1. We have one at 1.3, 1.6, 1.9, and those might warrant some further investigation. I really want to emphasize that a SAR greater than 1 does not mean that use is inappropriate, and a SAR less than 1 does not mean that use is appropriate, right? It's simply going to be an objective measure of use that then we need to investigate further. And so this is how we can compare at the state level for the facilities that are submitting the NHSN AUR data. And we do have some national comparisons available as well through the CDC's ARPSP portal. So for this example, this is once again those all antibacterial agents for the hospital. You can see that Arizona is kind of hovering around the 0.85 range, whereas other states may have more, may have less. So this is a way that we can kind of compare outside of the state as well. So in terms of setting a SAR target, this really isn't going to be a one-size-fits-all. This is going to be unique to what SARs need to be targeted in terms of what's outliers, your patient population. Perhaps if your antifungal SAR is high, then that antifungal use is warranted here in the land of Coxie, right? So essentially these comparisons provided by ADHS allow a starting point of how other facilities are performing in Arizona, which may assist in determining what an appropriate target might be. So So if the majority of our facilities have a SAR kind of clustered around 0.8 to 1.2, and your facility is at 1.5, then that might indicate that either you have a patient population that differs from the majority of the state and the use is warranted, or a little bit more investigation and stewardship needs to occur. So some potential approaches when kind of figuring out where you first want to focus would be which SAR is highest. That's probably going to be a good starting point to indicate an outlier to the expected use, as well as the use among other facilities in the state of Arizona. You can also consider which SAR is going to have the greatest impact on patients if lowered. Recall that we have one specific for medications with a high risk of C. difficile infections. And if you have high rates of C. difficile at your facility, maybe that's a good one to focus on. Or maybe it's going to be broad spectrum agents, such as the anti-pseudomonal antibiotics and the broad spectrum for hospital onset SAR, or the anti-MRSA agents in the gram-positive SAR. And then also feasibility, right, is also going to be a factor, which is going to be easiest to address at your facility. So maybe you can kind of hit a couple of those and focus on anti-MRSA use. If that's an elevated SAR at your facility, decrease potentially nephrotoxicity or other adverse effects that patients might experience, as well as work on your pharmacist for dosing it. So just some thoughts as you're considering it. And there is a calculation that you can consider called the Antimicrobial Use Cumulative Attributable Difference, or AUCAD. And so this is essentially the observed days, keep in mind that SAR is in the past, right, minus the predicted days times your new SAR target. And I really want to emphasize that you're kind of looking retrospectively here. And this may or may not be consistent as you're looking into the future, because the SAR has to do with how many patient admission days there are. So if your patient admissions are constant and your days of patients admitted is constant, then that aspect isn't going to change. But if you're a facility where that fluctuates in the summer versus the winter, then that's not going to be as reliable, right? So an example here, so this facility's current antifungal SAR is going to be 2. That's 1862 divided by 931 is 2, making our math easy this afternoon. And this facility wants to set a target of 1.62, just decrease it a little bit. So we take the observed days minus the combination of the predicted days and the SAR, subtract those. So if in that time frame they had decreased their antifungal use by 353 days, they would be at that target SAR. And I know that not all of us love math, as pharmacists have that reputation for. So essentially, NHSN will also do it for you. And that's going to be a little bit easier of a step, assuming that you have access to NHSN, which I would really encourage for any stewardship pharmacist or physician leading the program, as well as the infection preventionist at each facility. So on the left is going to be a screenshot of the analysis and report types after you make sure you generate current data sets. And then on the right is going to be an example of where you're typing in what SAR you want to target, and then it calculates that cumulative difference in days for you. So as another example here, let's say that this is the report that we receive. So this is going to be the gram-positive SAR, so our anti-MRSA agents on wards, so medical surgical units, for the second quarter. And I have a medium hospital group highlighted as our facility that we're looking at with a current SAR of 1.2, so just above what some might consider the target at 1. So let's say the predicted days of therapy was 1,000 and their actual days of therapy used was 1,200, which gives us the SAR of 1.2, and they'd like to target 1. So even though that math is kind of easy to do, just seeing the predicted and actual with the target being simply 1, you would need to decrease by 200 days to reach your goal. And I really want to emphasize here, this does not mean that for this scenario, 200 days would be inappropriate. That would require further investigation to make that determination, but it could be kind of a starting point in terms of a goal. And I also want to emphasize that target, assess, steward are not going to be a linear process. And I would actually kind of advocate for hopping back and forth between the different strategies and maybe performing some assessment before setting a SAR target as well. But you kind of need to start with knowing where to look. So let's move into the assessment portion a little bit more. So when you want to identify target medications, you can look at facility drug-specific use or perhaps spending data. That's usually something that can get good C-suite or administrative buy-in. And when you're looking at facility-specific drug use, maybe you want to consider the broadest spectrum agents from a stewardship perspective. Maybe you want to look at those with the highest cost or those with the greatest additional work, such as monitoring of vancomycin or aminoglycosides or the mold-active triazoles. And one of the things that NHSN does to help you identify these is they'll tell you the 3 highest use drugs within the target SAR. So if we look at this first example for kind of in the background, the third quarter of 2022 for their step-down units, they can see the predicted days and the observed days, the cumulative difference that we want, and then their highest use in that category is going to be vancomycin. So that would be their target. And then on the forward screen, just once again looking at that top row, we see that the highest use drug for that was amoxicillin would be the target there to consider. If you want to focus on those highest use drugs, that's usually where you might have the most opportunity compared to one that is less frequently used. There's a lot of different ways that you can look at medications and try to target different aspects as you're collecting data. So for example, the SARs are for the ICU or medical surgical units, but perhaps you have one ICU or one specific ward that's driving up that SAR and having higher use, and that's where you want to focus your investigation. You may also want to look at the average duration of therapy. If you have indications reported on your antibiotics and you're seeing 14 days for skin and soft tissue infection or community-acquired pneumonia, maybe that's an area that you want to focus on. Similarly, just focusing on all use for any indication like diabetic foot infections or febrile neutropenia may have more recently updated and clear-cut guidelines that you can look at and hone in on those. You can also consider if appropriate diagnostics are ordered, right? If you have a urine culture ordered before treatment, antibiotic therapy for UTIs is given, or if you are seeing a lot of vancomycin use for presumed MRSA pneumonia, evaluating if MRSA NAIRs are ordered for potential de-escalation and discontinuation rather than completing a full 7-day course. And also along the lines of a urinary tract infection, we want to ensure symptomatic infections for any of our non-sterile cultures. So that could be another thing to look at. So it could be urine, skin or wound, respiratory tract, ensuring that there's that clinical syndrome that warrants treatment. You could also look at unnecessary combinations. This is a pretty low-hanging fruit in the world of stewardship, particularly double anaerobic combinations. This may not impact SARS directly, but it's a good stewardship low-hanging fruit to address. You may want to start with spectrum and focus on the novel beta-lactam or beta-lactam, beta-lactamase inhibitors. You may want to focus on fluoroquinolones at your facility, and that would be reflected in your SARS. Or as you go through this, perhaps there's certain prescribers that you would like to focus on their prescribing patterns, particularly if anecdotally you believe it may not be guideline concordant. Collect that information, and that can allow for a more detailed peer-to-peer discussion or just kind of evaluation occurring. And so after you've kind of thought about what sort of agent and what sort of patient population you want to look at, you would want to perform a medication use evaluation. And the next step in that would be define what you would consider appropriate, because you're wanting to identify inappropriate use in order to decrease that and make sure that the use of your antibiotics are appropriate. So an easy way, if you have recently updated guidelines, which may not be the case in the realm of infectious diseases, would be to evaluate guideline concordant or evidence-driven use. So one example would be for febrile neutropenia, evaluating the MRSA risk factors and if it's present for the patients receiving vancomycin, and having those as a binary yes or no on the spreadsheet that you're using to collect this information. And then you also have to consider how much leeway do you want to give in the presence of septic or septic shock, right? Do you consider admission to the ICU an appropriate reason for the patient to be on anti-pseudomonal coverage or carbapenem coverage or MRSA coverage? So all of those need to be kind of figured out in advance. And I would really advocate for discerning empiric from definitive treatment, because if it's culture driven, obviously it's going to be appropriate, assuming the patient has an infectious syndrome, but empiric can be appropriate for the first 2 to 3 days while we're gathering data, especially in a more critical patient. So after you've kind of thought through those things, you determine what data points to track, create your data collection tool. I typically use Excel for this. And you can evaluate the regimen from multiple perspectives. Who's the prescriber? What unit are they on? What's the indication? What was the duration? For a single drug, you can also evaluate empiric use and definitive use, kind of re-evaluate the course at about 72 hours, and perhaps reach out as well. It may all be kind of along those lines. It may also be helpful to track the stewardship team's intervention on potentially inappropriate recommendations or regimens, and if those recommendations were accepted or not, which can help guide further discussions and also show the impact of your stewardship team, which is really important. So then you want to collect the data and share it. And I really would encourage you, as you're sharing this data with your key stakeholders, committees, providers, C-suite, that the conversations are approached in a curious and collaborative manner, because there may also be components that aren't documented well in the medical record in terms of clinical concern, or just other considerations that you can't be aware of as you're collecting data, or that you weren't able to take into consideration when you're forming your data collection sheet. We're all human. So as I was mentioning with febrile neutropenia and calling out MRSA risk factors, I was alluding to a medication use evaluation that we did at my last facility, and we looked at all the different components of febrile neutropenia management. So this was a smaller number of patients, only about 28. I would encourage closer to 100 if possible, but we didn't have as many patients who fell into this category during this time frame. So the vast majority received an anti-pseudomonal agent, which is appropriate. Many also received an anti-MRSA agent, although 8 of those did not have guideline-directed risk factors. Many also received an antifungal agent, which is appropriate since we were a stem cell transplant center. And many also received an anti-anaerobic agent, which would have specific risk factors, such as concern for an intra-abdominal source of infection. So in total, we had 10 regimens that had at least one inappropriate or non-guideline concordant component, as well as 18 appropriate, and recognized that overuse of vancomycin and other anti-MRSA agents was an area of opportunity for us. So moving on to the last section would be steward. And really, the intervention is going to depend upon the data collected during the medication use evaluation, but potential questions to consider would be, are the courses inappropriate at the start of therapy? Is it something that needs to be addressed during that initial empiric ordering? Or is it more so definitive therapy and de-escalation where education and intervention is needed? And if it's de-escalation, do you have the staff bandwidth to carry this out? And also, are antibiotics being given for the shortest appropriate duration for that patient? Since we know that the duration of therapy would obviously impact the SAR, we're getting a lot more data regarding shorter courses of therapy being equivalent to longer, as well as additional benefits in terms of resistance rates. So that would be something to consider as well. Like I had mentioned, a 14-day course for community-acquired pneumonia. And then, are we seeing certain indications or perhaps prescribers or specialties potentially driving inappropriate use, where that could be an area of opportunity for the stewardship team to have peer-to-peer communication as well? And there's a few different ways that you can consider implementing these interventions. So the first would be feedback, which is really best for clinician-specific concerns. And prospective audit and feedback is really a gold standard in terms of stewardship. And if your facility has the staff bandwidth, I would really encourage that this be implemented, at least in a targeted way. Education is a good first step to improve practices, but it often doesn't result in sustained change. So I would really pair this with a more impactful and sustained intervention. So this might be something like facility-specific guidelines, order sets, policies, protocols, or EHR changes. And these tend to be more lasting. Of course, nothing's going to be perfect. Everything can be overridden, but there are a few different categories to consider. And if this is something that the facility is starting out with, I would really encourage just one intervention at a time to keep it feasible and allow focus on that change. Now, you also want to monitor the stewardship interventions. We're here talking about the SAR, so that can be an outcome or a process measure, but that would be something that you want to keep an eye on and that you will be by receiving our reports. And there's really the two different types of measures to kind of back up a step. So process measures are things that are clearly within our control, our processes as we're managing a patient, whereas outcome measures are going to have probably some confounding factors and maybe more down the road that might be harder to see during a single hospital admission. So examples of process measures would be what's the rate of using an order set compared to ordering that medication individually because maybe there's other components we want with it. An example here would be I created an amphotericin order set at my last facility to ensure that the hydration and the pre-medications were given with it instead of just the drug being ordered by itself and then needing to clarify those components with the ordering provider. We can also evaluate the ordering of appropriate diagnostics, like we talked about MRSA NAIRS when an MRSA agent's being used for pneumonia, or a C. diff test before initiating treatment for C. diff, the number of interventions from the stewardship team, as well as the acceptance rate of those recommendations. Guideline and evidence concordant prescribing is a good one. If your facility doesn't consistently document the indication, that's a good first step to gather more data and try to push as a best practice. The appropriateness of therapy, both empirically and definitively. Similarly, once you get culture results, the time to appropriate therapy. The frequency of de-escalation or discontinuation if you're evaluating empiric therapy, particularly once you have those culture results back, and the performance of therapy reviews by either the treatment or the stewardship team to make sure that's occurring after 3-ish days. For other outcome measures, you might want to look at antimicrobial spending, incidence of multi-drug resistant organisms. So if we hone in on decreasing fluoroquinolone use, we should see actually increased fluoroquinolone susceptibility in the coming years as we decrease the use of those agents. We also want to look at the incidence of C. diff as a potential outcome if we decrease the use of those antibiotics that might trigger that infection. The hospital length of stay. Mortality is always something that we care about, hopefully no difference with our stewardship interventions, but good to keep an eye on, especially if therapy isn't being escalated with culture results. We also want to look at clinical success and cure to make sure that's not being compromised as we de-escalate and ensure appropriate prescribing, readmission rates, and rates of adverse events as well, which I really think of with the gram-positive SAR and anti-MRSA agents. So as an example, going back to my febrile neutropenia, I don't have a picture of my order set, but I found this one online that gives the examples of listing out the risk factors of when to provide MRSA coverage in the setting of febrile neutropenia and building some of this guidance into the order set so that it's there as a quick reference when the prescriber is choosing their regimen can be very helpful. So to kind of go through the summary, the CDC recommends a target assess steward approach to the SAR data, which target is going to be identifying an anti-infective use target, assess the current use of agents and opportunities for improvement, and stewardship is taking action to enhance at least one facet of prescribing. And these steps can be performed in any order and really should be cyclic. It's going to be unique depending on your circumstances. This isn't going to be a one-size-fits-all for the SAR or the approach with how to address it. Some resources that I wanted to point out is the CDC has a Keys to Success with TASK website as well as a guide. They also have strategies to assess antibiotic use to drive improvement in hospitals. And I also wanted to call out the Duke Antimicrobial Stewardship Outreach Network, and they have a lot of examples on their website of using SAR data and turning it into stewardship interventions and how to kind of interpret and monitor some more examples compared to what we went through today, although essentially along a similar strain. If you need help with NHSN, they have an email. And of course, here at ADHS, we're always here to help as well. We have our stewardship and surveillance team, which also includes To, another infectious diseases trained pharmacist, myself, Rachana, our manager, Swathi, who you heard from, Neil, who's our infectious diseases physician consultant, and Tracy, who you received the reports from on our surveillance team. That concludes my presentation. Thank you everyone for your time and engagement today. I really appreciate it. And please feel free to reach out via email if you have additional questions that you would like answered, or if you would like to meet individually to have a discussion with us about the report or potential next steps. We're always happy to do so. So thank you.